Ladies and gentlemen, thank you for joining the Lake Superior Quality Innovation Network. Screening and addressing alcohol use in primary care. Your host for today is Mark Klaus. Please begin.
Thank you so much. Hey, good afternoon, everyone. Evening. Welcome to the December Lake Superior Quality Innovation Network Learning and Action Network webinar. I know I said network twice there. This is actually a Learning and Action Network event, and I'm very happy to present this material to you today. My name is Mark Lausch. I'm a social worker by vocation, and today we're going to be talking about how primary care physicians, nurses, social workers, and care managers can effectively screen and assist their patients who may be using alcohol in risky or hazardous ways. We'll not be offering continuing education credits on this presentation, unfortunately, but we will have an evaluation that will come up at the end of my presentation, and I would be very grateful if you would take a couple minutes and fill the evaluation out. We at Lake Superior Quinn take your feedback very seriously, as I do personally, because it always helps me figure out ways that I can do these presentations a little better in the future. The slides in the presentation will be available at the conclusion of the event. You can get a copy of the slides if you email me at mlausch, L-O-U-S-H, at mpro.org, and that is in the chat box. And it'll also be on our YouTube channel, our LSQN YouTube channel, in about 5 days or so, if you want to view it at that time. If you have any questions, you can either save them to the end. I think we'll have a few minutes to throw some questions out there at the very end. Or you can put them in the chat box, and I will answer them at the end of this presentation. Okay, so today's objectives. Today we're going to try to identify the primary reasons why screening for alcohol in primary care is important, understand how to use the three basic alcohol screening tools, the CAGE, the audit, and the audit C. We're going to describe how to advise patients on hazardous drinking behaviors, hazardous or risky drinking behaviors. Identify some community resources and how to access them, and then briefly just examine some common medications used to treat alcohol use disorders in primary care. During this presentation, I will explain to you some of the basic concepts on addressing alcohol use in primary care. So this is, just so you know, this is in no way a complete presentation or definitive in scope or material. I won't be addressing how to diagnose alcohol use disorders. That's a completely separate, probably a full webinar in and of itself. So what I'm going to be talking about today is risky and hazardous drinking and how to talk to your patients about that. So I'm going to use the term risky and hazardous interchangeably during this presentation. So the terms imply the same thing. You know, a patient is drinking more alcohol than they should, and they would likely benefit from decreasing their alcohol consumption. So again, we're not making the distinction that they have an alcohol use disorder, they are alcohol dependent, or they're an alcoholic. That's something that requires further evaluation. We're just talking about screening and looking at risky and hazardous drinking behaviors. Okay, so a little bit about alcohol use. About 1 in 3 adults in the U.S. engage in hazardous drinking. So that is defined as drinking that elevates their risk for physical, mental, or social problems. So of these hazardous drinkers, about 1 in 4 will have an alcohol use disorder as defined by the DSM-5. So in a recent study of primary care practices, patients with alcohol dependence received recommended quality of care, which included assessment and referral. They were only about 10% of those patients were likely to be referred to recommended treatment. Okay, so the point being that it's definitely under screening for alcohol is not utilized very frequently in a formalized sense in most primary care practices. They may ask questions about alcohol use, but it's rare that there's a formalized process for screening and identifying patients with risky or hazardous drinking and referring them to appropriate outpatient services or inpatient services if that's needed. And I'll talk a little bit more about the prevalence of those that you may see in your practice that will require intervention. It's actually very small. So you have a key role and ability to make a difference. Clinical trials have shown that brief interventions by primary care physicians can promote significant and lasting reductions in drinking levels for at-risk drinkers that have not progressed to alcohol use disorder. So this would be those that are just using alcohol in a risky or hazardous manner. And only a small percentage of those you see and screen will require referral to specialty alcohol use disorder services, such as detoxification, inpatient, or outpatient treatment. The statistic on the slide is about less than 10 to 15%. We're going to see another slide later in the presentation that really looks at probably right around 5 to 7% of patients that you screen will require referral outside of your practice. And the remainder of those can be addressed by doing brief advice and some motivation interviewing strategies and things we'll talk about a little later. Okay? Even those with severe alcohol use disorders will at times accept referrals for specialty treatment. The old myth is that, the alcoholic is going to be, or the alcohol dependent person is going to be, real resistant to treatment and they're going to refuse. And even the most, who you might think would be the most resistant patient, sometimes they can generally be open to your interventions, okay? And those that refuse initially may accept it in the future, even with repeated refusals. Continued discussions with patients about their hazardous drinking behaviors can lead to significant improvement in them reducing their drinking, okay? And again, I'll talk about this later. The goal is not necessarily abstinence, okay? Abstinence-based treatment is fine if you have a patient that has very significant alcohol use disorder, is alcohol dependent, or identifies themselves as alcoholic. And so abstinence-based treatment may be the best course of treatment for them. For your hazardous and risky drinking behavior patients, getting them to reduce the amount or the frequency of drinking is a very, very significant goal and well within your domain and your abilities to intervene. Okay, so let's look at it for a minute at the impact risky and or hazardous drinking can have on two chronic conditions, diabetes and cardiac conditions. So drinking alcohol hinders the liver from releasing stored glucose, and this can lead to dangerously low blood levels. It takes about 2 hours for the liver to break down the alcohol that is contained in one drink. So that energy spent in doing that would otherwise be utilized for a healthy release of stored glucose. So all told, alcohol slows down the body's reaction time, disrupts the liver's ability to release glucose, and may cause individuals with type 1 or 2 diabetes to slowly develop hypoglycemia. Alcohol abuse also causes a condition known as hyperalgesia, in which the already damaged nerves become even more sensitive to pain. In other words, if an individual with diabetes is already suffering from pain due to nerve damage, alcohol abuse can dramatically increase the amount of pain that is felt. Therefore, alcohol abuse makes it much harder for the body to control the pain that may have already developed due to diabetic nerve damage, and in doing so makes the individual's condition dramatically worse. An occasional drink may cause temporary double vision or blurry vision, but alcohol abuse can worsen any type of eye disease that may have been caused by the individuals with diabetes. So alcohol slows down the brain activity, which causes the pupils to react more slowly, and this alters their ability to widen or constrict properly. Over time, this also permanently weakens the muscles in the eyes. There's hundreds of muscles in the eyes, and alcohol permanently weakens them over time. As a result, alcohol abuse can lead to blurred vision or double vision that is permanent, especially in diabetics or persons with diabetes who may also have an existing vision problem. Alcohol abuse also causes blood vessels in the eyes to swell, and this produces a red bloodshot appearance. Rapid eye movement, in which the eyes voluntarily move back and forth, may develop over time as well as in the individual abusing alcohol. Finally, alcohol can impair the ability of the individual's ability to self-manage their diabetes, right? Impairment from alcohol causes poor decision-making and poor choices in diet, exercise, medication usage, and other important self-management skills. Go to the next slide, and we'll talk that related to persons with diabetes. We're going to talk a little bit more now about the impact of alcohol on cardiac conditions. So some of the cardiac complications associated with hazardous or risky alcohol use include it raises triglycerides in blood, it can lead to high blood pressure, heart failure, and increased caloric intake. Excessive and binge drinking may lead to stroke, cardiomyopathy, cardiac arrhythmias, and sudden cardiac death. So the question becomes, what about red wine? So over the past several decades, many studies have been published in scientific journals about how drinking alcohol may be associated with reduced mortality due to heart disease in some populations. The idea being that if you drank red wine at a moderate level, that would reduce your cardiac risk. Some researchers have suggested that the benefit may be due to wine, okay, and especially red wine. Others are examining the potential benefits of components in red wine, such as flavonoids and other antioxidants in reducing heart disease. Some of these components may be found in other foods, such as grapes or red grape juice. So the linkage reported in many of these studies may be due to other lifestyle factors other than alcohol. Such factors include increased physical activity, a diet high in fruits and vegetables, and lower in saturated fats, and no direct comparison trials have been done to determine the specific effect of wine or other alcohol on the risk of developing heart disease or stroke, or in reducing the risk of cardiac problems. So what does it mean? It means that, as everything, moderation is probably okay, but, obviously drinking red wine is not a way to improve your cardiac health. So I guess that's the point I wanted to make with that, is that, red wine is probably okay if the patient has an alcohol use disorder or riskier hazardous drinking. It's probably not a good suggestion to recommend red wine as a cardiac tonic. Okay, and finally, just to throw this out there, that for clinicians reporting for Physician Quality Reporting System PQRS program in 2016, and for the Quality Payment Program for the Merit-Based Incentive Payment System, MIPS, in 2017 and beyond, the Centers for Medicare and Medicaid have developed a measure under the Community and Population Health domain to address unhealthy alcohol use. So this measure is known as PQRS 431, or National Quality Form NQF 2152, and provides guidelines on treating patients 18 years and older using systematic screening methods once during a 24-hour period, and who receive brief counseling if identified as an unhealthy alcohol user. So you can use alcohol screening to meet PQRS and MIPS reporting requirements. So it's a positive thing. If you haven't thought about doing this now, it's good to consider this, because this will be part of MIPS as we move beginning in 2017 and moving forward in the future. Okay, so let's get down to brass tacks here and talk about what is normal drinking, right? So, as you can see, normal drinking for most patients would be no more than 2 drinks a day for men, 1 drink a day for women. Now, a standard drink is considered a glass of wine, a beer, or a shot of liquor. It is important to know, though, that most people who pour drinks in their homes frequently underestimate the amount of alcohol they consume, because they mix their own drinks, and they frequently put more than 1.5 ounces of distilled spirits in a cup with their vodka or gin or whatever they're drinking with their mixer. Okay, they tend to be very heavy-handed. Many craft and specialty beers also contain higher concentrations of alcohol and are often presented in bottles that contain more than 12 ounces, right? So, if a guy tells you he's drinking, 2 beers a day, and they're, 48 ounce, mega, ultra, whatever they're called, and the alcohol content is significantly higher, he's probably drinking the equivalent of 3 to 4 to 5 beers a day. So it begs to be assessed a little bit more, and we'll talk about that later. So it's important to consider asking the patient about his or her drinking, and the next slide illustrates that a little better. This is just this is from our our alcohol pocket guide that is available. I can make that available to those of you who want a copy of it too. It's a laminated guide that on one side of the guide is the drinking guidelines, and this one for moderate alcohol consumption. This is just a screenshot of one part of that alcohol consumption part of the pocket guide, and it's moderate alcohol consumption, riskier, hazardous, binge drinking, and heavy drinking on one side of the sheet. On the flip side is scoring guidelines for the alcohol screening test, and it's pocket size. It's meant to fit into a lab coat. It's laminated, so it won't bend or break. This is from our alcohol pocket guide. So this is the one I wanted to go to, the standard drinks. And as you can see that, obviously that there are some drinks that contain significantly more alcohol than what would be considered a standard drink. Okay? Let's talk about at-risk or hazardous drinking now. So how much is too much? We looked at what is considered normal drinking, which is no more than 2 drinks a day for men and 1 drink a day for women. So drinking becomes too much when it causes or elevates the risk for alcohol-related problems, or it complicates the management of other health problems that you may be treating the patient for, such as heart disease, diabetes, hepatic impairment, kidney disease. So the SAMHSA guidelines are at-risk or hazardous drinking is for men, 4 or more drinks per day, or 14 drinks per week. Women, 3 or more drinks per day, 7 drinks per week. Okay? A patient's drinking becomes hazardous or risky when it causes problems, right? So when drinking complicates the management of other medical conditions, or it causes or increases the risk of other health-related problems. Father Joseph Martin, also known as Father Martin, was an Irish Catholic clergy and recovering alcoholic. Father Martin was popular in the 70s and 80s, and he was all over the place when I was coming up in this field. And every treatment center, outpatient, inpatient, used his films. Now, I'm dating myself here, but when I first started working in this field, when I used to show material to patients, we actually had a film projector with a film on a reel that you spread it through a projector to play. Then they got hip, and what they started to do is videotape the projection of the film on the screen, which left a lousy third-generation copy of whatever they were showing. But anyway, Father Martin was all the rage, and he's funny, he's recovering, he understands a lot of things about alcoholism, but he did a series of presentations that he called Chalk Talk and the 12 Steps of Alcoholics Anonymous. And in Chalk Talk, he used a phrase that has always stuck with me throughout my entire career, and it's really been the basis of how I would assess patients if I'm looking at assessing their drug or alcohol usage. He said, a problem is a problem if it causes problems. Very, very simple. Makes a lot of sense. Okay? A problem is a problem if it causes problems. So that's how I've always approached patients in looking at whether drinking is at risk, hazardous, or dependent. Alcohol abuse, alcohol dependence, those are old terms from the ODSM. Now they call them alcohol use disorders. But is your drinking causing problems? The problem is a problem if it causes problems. And I've used that language with patients before, and they've responded well to that. I mean, because it makes perfect sense. So to finish this out, let's talk about heavy and binge drinking in men and women. And again, the graphic on the right of the slide is taken from our alcohol pocket guide. And so heavy drinking is considered 5 or more drinks on the same occasion. So you're drinking 5 or more drinks, doesn't matter how long that occasion is. On 5 or more days in the past 30. Okay? And binge drinking is really similar. I mean, I don't think there really needs to be, if you want to get specific about it, I think really what we're looking at is the 5 or more drinks on the same occasion. And then the binge drinking includes 4 more drinks in less than 2 hours. So a lot of heavy drinkers will meet that criteria too. So sometimes 5 or more drinks on the same occasion, they may be drinking 4 or more of those in less than 2 hours on some occasions. So you can be a heavy and binge drinker in the same in the same person. Now, binge drinking is often sometimes harder to detect in patients and for them to identify problems related to their drinking because of the nature of binge drinking. If they're a true binge drinker, where maybe they're, the old concept of the weekend warrior, they don't touch a drop Monday through Friday, but Saturday or Friday night, Saturday while they're watching, or Sunday while they're watching football, or Friday or Saturday when they go out, they really hit it hard. They oftentimes, unless they're lucky or unlucky enough, depending on how you look at it, to get a DUI or have significant relational issues or at home, they're going to be hard to detect because they're not drinking oftentimes on the periods in between their binges. So those patients can be a little hard to kind of detect. So heavy binge drinking, really, when you're looking at that, you really don't, between the two, it's probably not something you're going to want to address in your practice. It's just going to be hazardous or risky. If they're drinking at these levels, they're drinking as hazardous or risky, and that's really all you need to know. If you're referring them out to specialty services, like a substance abuse therapist or an outpatient clinic, they can worry about the further refinement of their diagnosis in looking at that. But for from the point of a primary care practitioner, it's just hazardous or risky. Just a couple things on the prevalence of drinking. So from statistics in 2014, about 87% of the people ages 18 or older reported they drank alcohol at some point in their lifetime. So people are drinking, we know that, okay? We know that. But about 25% of persons over the age of 18 reported that they engaged in binge drinking in the past month. Now, that was from 2014, too. So the numbers of, people are drinking, right? So about 70% of people are drinking. 90% of people are drinking. It's 87.6. And the prevalence of binge drinking was about 25% over the age of 18. So there are people that are drinking in binges. There are people, considerable amounts of people that are heavy drinking also. So let's look now at the effects of risky or hazardous drinking. So we have immediate and long-term risks. And immediate risks are those things that you would probably associate with somebody who is drinking alcohol. So these are things that that can be intended or unintended: motor vehicle crashes, injuries, drownings, falls, partner violence, child abuse and neglect, the property crimes, things like that. Those are things you might expect. If you look in the field, you'll definitely see a lot of these in patients that come in for alcohol use disorders. Long-term risk, gastric issues, hypertension, liver damage, pancreatitis, the progression to alcoholism, the neurologic damage, and the like. In addition to those listed, you can add marital issues, legal issues, DUIs, alcohol-related driving offenses, occupational impairment, miswork, poor productivity, familial dysfunction, all those things. Now again, just because someone is drinking at the hazardous or risky level doesn't mean they're going to automatically develop any of these problems. It just puts them more at risk for that. And these are, I think, things that can be used when you work with patients and talking to them as a medical professional, as their physician, as their nurse, as their care manager, as their social worker, to talk to them about, if you continue drinking at these risky and hazardous drinking levels, these are some of the things that you may encounter. For a while, in a past place I worked, I did evaluations for a legal firm that specialized in drunk driving evaluations, or drunk driving litigation, and they hired me to do evaluations for their patients that came to them for services. And they weren't sending them to me to try to find a way to get out of being adjudicated. They wanted to know truly if this patient had an alcohol problem. And I can tell you, probably out of over 100 evaluations that I did for them in a 2-year period, probably about 30% of the patients that I interviewed had what I would consider alcohol use disorder or alcohol dependence. So that was like 70% of the patients that got DUIs. They weren't alcoholic, they weren't alcohol dependent, they weren't, they didn't have an alcohol use disorder. They were using alcohol at risky and hazardous levels on occasion. Okay, they might be considered quote unquote binge drinkers. Okay, but they weren't people that you would necessarily refer into an outpatient claim for treatment. So I talked a lot to them about some of these immediate long-term risks when I used to evaluate them and say, if you continue drinking in this manner, these are some of the things that might happen to you, and additional DUIs are very, very pricey and very, you're going to jail if you get more than one DUI. You might go to jail if you get one now, these days. So now we're going to move on now to talking about the screening tools used to screen for alcohol. First one we're going to talk about is the CAGE. The CAGE is an acronym for the first four questions that are included in the screen. So the CAGE is a validated, recognized tool by SAMHSA, CMS, commercial payers. It's a validated and reliable screening tool for alcohol. The only caveat I give you on the CAGE is that it is not recommended by the Joint Commission. So if you're a Joint Commission accredited outpatient facility, or you work with you work in a hospital system, or employed by a hospital system that is Joint Commission accredited, the Joint Commission doesn't recommend the CAGE. Why is that? The CAGE tends to identify more problem drinkers and may miss those with less severe symptoms. Okay. Even though it's still a validated tool, it's still a recognized and validated tool, it's easy to administer because it's mnemonically remembered. So the four questions are, we know the next slide, I'll show you the four questions. The four questions are, I thought we had the ones with the questions, but we don't, but I'll tell you what they are anyway. The first one is, have you ever attempted to cut down on your drinking, which is the C. Has anyone ever expressed annoyance with your drinking, which is the A. Have you ever felt guilty about your drinking, which is the G. And the E is, have you ever had an eye opener or a drink in the morning, or a drink to mitigate against a hangover. So as you can see that some of us problem drinkers, a lot of people don't have eye openers. I mean, it's just not something a lot of people do. So, and they may not feel guilty about their drinking, right? Because they may be drinking at risky or hazardous levels, but they're not necessarily feeling guilty about it because nothing's really happened to them. And people may not have expressed annoyance about them. And they may not have attempted to cut down. So as you can see, that the CAGE is a good scoring tool. It's a decent tool, but it tends to identify more problem drinkers. But we do have some practices for using the CAGE, and it does, it is a validated, appropriate screening tool to use. So I guess the flip side of that would be, well, in a primary care practice, if you're not identifying more problem drinkers, at least you would know those that might require more intervention or referral or referral out. So the CAGE scoring, go back one. The CAGE scoring is simply, there's score 0 or 1 for the four questions. A score of 2 or greater is considered clinically significant, and really any score of 1 or above probably should be further evaluated for potential misuse, abuse, or dependence. Again, those three, so that could include risky or hazardous drinking too. Remember, screening tools are just screening tools. They're screening. They're not diagnosing. They're just screening. So really, in the CAGE, any score should be discussed a little further with the patient. Okay, the next tool is the Alcohol Use Disorders Identification Test, or AUDIT. This is a 10-question validated, reliable, used by many. The domains of the test include hazardous drinking or hazardous use, dependent symptoms, and harmful use. There are both self-reporting and clinician-administered versions, and the AUDIT C is more reliable than CAGE in screening for early, risky, hazardous drinking. Okay? Here are the domains of the audit. The first three questions of the audit contain questions that try to assess or screen for hazardous alcohol use, frequency or type of drinking, the typical quantity, frequency, heavy drinking. Questions 4 to 6 look at dependency symptoms, impaired control, loss of control, morning drinking. And the last 4 questions look at harmful alcohol use, guilt, blackouts, alcohol-related injuries, others concerned about drinking. So if you can see, some of the last 4 questions that really look at harmful alcohol use are similar to the CAGE questions. So the audit is generally a better tool for kind of sussing out less risky drinkers. And the audit C is a modified version of the audit. And the reason I don't spend a lot of time on the audit is because most of our practices are using audit C. The audit C is 3 questions, very simple, modified version of the audit. It's actually the first 3 questions of the audit. It's validated and accepted. And it also can be used as a first-line screen with the full audit to be used if a patient tests positive. So much like you might use a PHQ-2 for depression, for the initial screen, if they answer yes to either of those questions, then you would administer the PHQ-9. The audit C can be used as a first-line tool, where you would give the audit C if they scored within range, and we'll get to that in just a second. If the score was within range, you could then give them the full audit, the 10-question audit, which would give you a little more specificity and give you a little more information about their drinking behaviors. So the audit C questions are simply, how often do you have a drink containing alcohol? How many standard drinks containing alcohol do you have on a typical day? And how often do you have 6 or more drinks on one occasion? Next slide. And so the audit C is scored on a scale of 0 to 12. So 0 being no alcohol use, and each audit C question has 5 answers, and they're scored 0, 1, 2, 3, or 4. So in men, a score of 4 or more is considered positive. In women, a score of 3 or more is considered positive. Remember, you're just screening positive. I mean, simply that you want to talk to your patient a little bit more about that. So generally, the higher the score, the more likely a person's drinking is affecting his or her health or safety. Okay? Okay, so we talked a little bit about what's normal, what's at-risk hazardous drinking, what's binge drinking, what's heavy drinking. We talked about CAGE, about the audit, and about the audit C. Now, talk a little bit now. The rest of the presentation is going to be about advising patients about their drinking or talking to them about their drinking. So for patients that score positive on any of the alcohol screens, the first thing you probably want to do is ask them in more detail about their drinking behaviors. How much, how often, how many days per week, per month, type of alcohol consumed. Are they mixing drinks at home? Are they drinking 4 to 5 drinks? Are they drinking mixed drinks that contain 2 or more types of alcohol in them? What medications are they using? Are they using any opioids, benzodiazepines, anxiolytics, over-the-counter sleeping medications, things like that? So don't feel intimidated about asking these questions, but always preface the question by asking permission of the patient. Is it okay if I ask you some questions about your drinking? Okay? That's important because it tells them that you care about their answers and that you want to help them. So if they say no, you move on. Okay, we'll catch this the next time. And so you're opening the door for them. Is it okay if we take a few minutes to talk about that? And if they say no, then you move on. So it's important too, as the slide says, it's develop an elevator speech about what you're trying to accomplish with this. So they don't ask you the question, why are you giving me this alcohol screen? So you can say something like, because we care about your health and we want to provide the best quality health care. We discuss with our patients all issues that affect your general health, such as smoking, exercise, diet, your mood, and alcohol use. And that way they don't feel like they're singled out. They don't feel like their defenses aren't ramped up right from the beginning. Why are you asking me about this? Because we ask everybody Okay, so again, we're going to ask permission. Can we talk about that now? Inquire about their drinking, amount, type, frequency, that type of thing. So one thing to remember, though, is that everybody, when they're looking at the potential or the possibility of behavior change or are being asked about behaviors that may need changing, they go through stages of change, which were conceptualized by Prochaska and Velser, right? So the stages of change are pre-contemplation, meaning that they're not even considering changing at this particular point in time. Contemplation, where they're thinking about mulling over the stages of change. Then they would go contemplation, pre-contemplation, preparation, so they would plan to do what they're doing, behavior change. The next stage of change is action, where they're actually participating in stages of change. And then there's maintenance and termination. So patients go through these stages of change. It's not a fluid progression. It's a very, it's an up and down. It's up and down or back and forth. So, if you're inquiring about their drinking, at one point in time they may be very open to it. The next time you talk to them, they may not be. So that's normal, and it's important to remember that. So if they say no to you, is it okay if we take a few minutes to talk about that? Nope, I don't feel like it. Okay, thanks. Thanks for being honest, and then we move on to the rest of the whatever they're there to visit you for, and you then maybe bring it up on the next visit. Okay, so some elements to include in your intervention. When you start to get a better understanding of their drinking patterns, amount, frequency, type, other substances, you've gotten their permission to talk to them, can I talk to you about this? You can provide feedback about their screening results. So you can use the pocket guide to inform the patient about what constitutes normal or social drinking. Those are, I can make those available to anybody that wants one. And you can then just show them that and say, hey, it looks like your drinking is in the range of hazardous or risky binge drinking or heavy drinking. You can just be upfront and honest and tell them about them and use the guidelines to show them. You don't need to be confrontational. You're simply pointing out the facts as reported by the patient and how their drinking compares to those SAMHSA guidelines that are on the pocket guide, or you can get them from SAMHSA. They're downloadable. You can just Google normal drinking levels, and you can get those and download those anywhere. So if they're drinking at moderate levels, risky or hazardous, you can ask them to list the cons and pros of their current alcohol consumption, or what they don't like and what they like. So it's important that you ask in that order, like don't like or cons first and likes or pros second, okay? That way, you can pay careful attention to what they say they don't like about their drinking and emphasize that, okay? And use that as kind of the discussion point. So you don't like this about it. Why is that? Tell me a little bit more about that. Pay careful attention, really, to what they don't like, because it can provide you clues how to proceed. So you can redirect them back to what you heard them say. You can ask for clarification if needed. You can reframe that. You can ask them to, you can paraphrase that. This is what I heard you. I heard you say you don't like this about your drinking. Is that true? So you're getting them to talk about and getting them to start internalizing some of those things that they don't like about their drinking, and that might motivate them to make small measures of change to change some drinking behavior. So as you get to this point, you can then ask them again permission if you could give them your medical advice, which then you could refer back to some of the long-term or short-term consequences of drinking and say, hey, as a medical professional, here's what I know about how drinking impacts your health in general. And if they have any specific chronic conditions that you're treating them for, you can talk a little bit about how alcohol may impact those specific chronic conditions. But just in general, say, hey, this is what hazardous or risky drinking behavior in the long term, in the short term can cause, and in the long term can cause. So at that point, when you're asking them, you might have given medical advice. Just like previously, if they say no, you're done. I mean, it's okay. It's not a good thing, but that's the reality. Sometimes they may say, no, I'm okay where I'm at, doc. I'm fine. I'm good. I don't want to do anything right now. Okay, so you've done the screening. You've recorded the results. You've done your quote unquote due diligence by asking them about it. And if at that point in time they say, no, I really don't care to talk about this anymore, that's fine. You can move on and let it go for now. You can bring it up at another point. You can set up a follow-up visit and try again next time. Listen for change talk. So change talk is comments made by the patient that indicates he or she is open to changing. It may be, they may be willing to change the amount they drink or the frequency of drinking. Or maybe they might say to you, my wife's been talking to me a lot about my drinking, or my husband's been saying I drink a little too much. Maybe it's time I cut down. Maybe it's time I do something about that. Maybe it's time I stop drinking. It's okay if they bring up the concept of abstinence. That's fine. So when you hear change talk, highlight these by using reflection and summarizing back to them the positive message of change you heard. What I hear you saying is that you're concerned about your drinking because it might cause your diabetes, your peripheral neuropathy to get worse. I think that's a good idea. How can we go about doing something about that? So, when you hear the change talk, you can ask them directly if they're interested in stopping drinking, changing their drinking patterns, or reduce the risk of future problems. So it's important to talk about, it says up here on the slide, establish a goal and action plan. Give the patient some choices. So again, as I said earlier, oftentimes it's not abstinence-based. We're not saying you're not telling your patient, you got to stop drinking completely. It's the idea of, what can we do to reduce your drinking to help you reduce your risk of further problems? Could it be that can we cut down on the amount that you drink? Okay? Can we cut down on the number of days you're drinking? Can we cut down on the situations in which you drink? Right? Can we try to can we cut down can we at least try to get you not to drink if you're driving a car? That type of thing. Things that would reduce their risk of further medical, physical, social, legal, financial consequences. So you can establish a goal and an action plan. Okay, so you have agreed to decrease the times you drink during the week to Friday and Saturday only. Is this correct? Okay, so you've come to the conclusion. You develop a goal and an action plan. Okay, and then you can set up an agreement for a follow-up visit, typically 4 to 6 weeks, to check on progress. And very important, thank the patient for being willing to discuss their drinking with you. If you get to that point where they're willing to hear you out, either, do you mind if we talk about your drinking, and they say yes, or when you get to the point of throwing your medical advice out or coming up with developing a plan for the reduction of their drinking, thank them for being willing to discuss it and working with you to develop a plan for that. Even those who are not willing to make changes now, you planted the seed. It might take some time to germinate. Remember, the stages of changes are fluid. The patient readiness to change is very fluid. Just think of yourself if you've ever attempted to stop smoking, lose weight. For me, it's exercise. It's like I went to the gym a couple of times a few weeks ago, and I went like 3 or 4 times, and I went like 3 times in 1 week, then 2 times the next, then 1 time the following week, and I haven't been in 2. So you can see that the stages of change are very fluid, contemplation, pre-contemplation, preparation, and action. It's like, they also go back and forth. So don't get discouraged if the patient is refusing to look at their drinking. If they come back in their follow-up visit and say, hey, doc, it didn't work. I couldn't do it. Okay, so we work on a different plan. Maybe we try the same plan again, or come up with a different plan. You are always having a positive impact, whether you realize it or not, when you suggest behavior change. You are always having a positive impact. Okay, and don't be discouraged. Okay, times to recommend or advise abstinence. If the patient is pregnant or trying to conceive. Takes medications that contraindicate alcohol use, such as Coumadin, a blood thinner. has other medical conditions exacerbated by their alcohol use, and or is using other sedative hypnotic drugs, opioids, or other mood-altering medications such as antidepressants, sedative hypnotics, anxiolytics, whether they be prescribed or over the counter, or if the patient makes the suggestion that they want to stop completely, they want to practice abstinence, then that's certainly it's certainly fine for you to advise that. That would not be that would not be pushy or contraindicated in motivational interviewing concepts to support that decision. Okay, so how long will an intervention usually take? Well, as little as 5 to 15 minutes of simple advice from a healthcare professional has been shown to have significant impact. Okay, significant impact. The number of patients who require a formal intervention. Abstaining and low-risk moderate drinkers comprise about 90% of the patients that you're going to see in your primary care practice. Riskier hazardous non-alcohol dependent drinkers, about 10 to 15. Risky independent drinkers, about 5%. So, what does that tell us? It tells us that about 90% of the patients you're going to screen, you're not going to have to do anything more for other than document that you screened them and their screening score was 0 or low enough not to require any more intervention. About 10 to 15 are going to be those that we just talked about, those that are drinking at hazardous or risky levels. They're not alcohol dependent, and that the dependent drinkers are about 5%. Next slide, please. And this drinkers pyramid from the Institute of Medicine kind of talks about the same thing, that abstainers are the low part of the pyramid, low-risk drinkers are the middle part, unhealthy drinkers are near the top, and about 7.5% of patients in the study from 1990 and 2005 were alcohol dependent. Okay, so a small or unhealthy drinkers. A small percentage of patients that you see are going to require referral out or intensive treatment. Okay, or intensive interventions by you or referral to specialty mental health services. Okay, so assisting patients to referral to specialty services. So we're looking at Southeast Michigan here, and in some major in this is where I'm talking from. We're very lucky. We have a myriad of inpatient, outpatient, intensive outpatient programs. Some of you listening to this may live in areas where these services are very, very few and far between. But detoxification is available. Inpatient, there is outpatient detox available now. There are inpatient programs, and those are just two programs that are near us that specialize in inpatient alcohol and substance use disorder treatment. There are intensive outpatient programs, and those typically meet about 3 hours a day, 3 days a week, and they include a group setting and some education about alcohol and substance use. There's outpatient sites, and I did this presentation for Henry Ford Hospital, so sorry, I forgot to take that Henry Ford Hospital system reference up there. And then there's 12-step programs available, and we do have an interactive map available for 12-step regions in Michigan. So as you talk to patients, make sure you document your referrals and patient response. And each of you will have your own methods for documenting your services that you provide. So make sure you document that you screened them, the screening tool you used, what the score was, and if you did anything with them, if you talked to the patient about anything, you gave them brief advice, or you referred them somewhere else. Okay, final thing we have here is medications used to treat alcohol use disorders. So the first one is the old school Andes from disulfide. So Andes interferes with the metabolism of alcohol. So what it does is it blocks the breakdown of acetaldehyde into acetic acid in the body, which causes extremely unpleasant side effects. Okay, so if the person drinks alcohol, the alcohol can't break down. It causes a rapid acceleration of acetaldehyde in the body, which causes flushed face, rapid heartbeat, sweating, vomiting, nausea, anxiety, and it's generally, from what people tell me, it's generally a pretty unpleasant experience to go through. The negatives about that is that it's an aversive therapy. It makes you feel bad. Aversive therapies generally, in some cases they work, but generally they're not a good first-line treatment to make somebody sick, to avoid a behavior, to hurt them, make them feel bad, or to not hurt them, but to make them feel bad and cause side effects to scare them away from drinking. It generally doesn't work as a first line, and a standalone without therapy or counseling, medical intervention. Many patients display tolerance to the effects, meaning they can drink on it. I've known lots of patients in treatment that I've treated that can drink, that were able to drink right on top of antabuse with no problems. Either the effects didn't bother them, or over time they were able to develop tolerance to those effects by continuing to drink alcohol. It requires daily dosing, so if they don't take it, it's not going to have an effect, and it's really not good as a standalone intervention. The next medication is Camprol. That's the trade name. The generic name is the Camprosate, and it is available in a generic form. It's believed to moderate neurochemical balance in drinkers to promote abstinence. So the mechanism of action is not completely understood, but Studies in animals have suggested that a camprosate may interact with glutamate and GABA neurotransmitters, glutamate and GABA neurotransmitters are sort of like sedative neurotransmitters, and it's populated to provide some balance in the brain, which in turn reduces cravings, and it's generally well tolerated by most patients. The results are generally positive from most of the studies I've read on Camprol. So it's a good medication to reduce cravings in patients that are probably patients that are probably at the risky, hazardous, or heavier binge drinking levels. Okay. And the final medication I'm going to talk about today is naltrexone, and it goes under the names Revia and or Dpaid. It's actually an opioid blocker. So it works by blocking opioid receptors in the brain by competitive binding. And it was initially used as a treatment for opioid dependence. And it was used, and the drug Revia was used, it was given to people who were freshly out of treatment. They've been detoxified, and what it did is it blocked the effects of opioids. So if they decided they wanted to relapse and they wanted to shoot heroin or take OxyContin or any kind of opioid, the naltrexone would block the effect, so they wouldn't get high. So that was thought to be a deterrent. There actually is a form of that in depot injection now called Vivitrol that is actually pretty effective in treating opioid dependence because it's a depot injection. It's put into the under the skin, and it lasts about a month. So it provides a pretty long-acting opioid blocking. So it can be an effective tool in treating opioid dependence. The oral use is Revia, which means you have to take it every day to pretty much be effective. But in drinkers, it has been shown to decrease heavy drinking, decrease the number of days alcohol is consumed, and the amount of alcohol consumed. So it is relatively safe for most patients, and this is a drug that can be used with patients that are in the moderate to risky category. And actually, a camprosate can be too, or Camprol can be too. It's relatively safe. It can cause hepatic damage, especially in heavy or dependent drinkers who may have hepatic impairment or may be more at risk for hepatic impairment. So it's recommended that liver function tests before or during treatment of naltrexone be used. So, in conclusion, screening is important and relevant. It contributes to improved outcomes with your patient. It really does. And it should be an overall part of your practice's approach to the overall health and wellness of your patient by looking at things like smoking, depression, drinking, and diet and exercise. Screening tools are easy to administer and score. Brief advice can improve your patient's drinking behaviors, and there are medications available to help your patient cut down and or maintain abstinence. And there are referrals available. And if you are working with us on the Behavioral Health Project, we can certainly help you develop referrals for your practice as you find patients who may need to be referred out. But remember, 5 to 7 to 10% of that's going to be the incidence of those patients requiring referral out for specialty services. It's not going to be a large chunk of patients. The majority of the patients you see are going to be with screening. They're going to be one and done. You're going to screen them. They're not going to they're not going to be drinking, or they're not going to be drinking at levels that require intervention. So it's not like you're opening a Pandora's box of problems if you decide to start implementing alcohol screening in your practice. I do have one question. Actually, we can open up for questions if anybody that's listening has a question. If not, I do have one in chat that I could answer.
Ladies and gentlemen, if you have any questions at this time, please press the number 1 key. Again, if you have any questions at this time, please press the number 1 key. And Mark, I'm waiting for the callers to join the queue at this present time.
You're waiting for? I'm sorry.
I'm waiting for people to join if you want to read that question.
Oh, okay, yeah. The question is, do you think the incidence of having a positive on the cage increases when providers use the cage aid? I don't know the answer to that question because I don't have the cage aid in front of me. I could definitely answer that for you, but I'd have to do that by email. I don't know that answer off the top of my head. Just so you guys know, the cage aid, I think, if memory serves me correct, the cage aid is similar to the cage, but it's for drugs and alcohol. I think it includes substance use in the form of the questions. So it's the same questions as the cage that you attempt to cut down. Anyone expressed annoyance? Do you ever feel guilty, or do you have an eye opener, or a substance to mitigate a hangover? I think that's what she's referring to. And I think we can put the evaluation questions up now. And if you guys could take just a minute to fill that out, I would greatly appreciate that.
Yeah, no one came in at 2 on this end.
Okay. All right, if you guys just hang on for 1 second, we're going to get the evaluation questions up there. Or WebEx operator, could we have the evaluation questions, please? There we go. Thank you so much. And while you guys are doing that, if you have any questions, you can please email me at mloush, M-L-O-U-S-H, at mpro.org. I really thank you very much for listening today, for participating in the webinar. I hope what I provided you is a good start to your practice as you move forward in considering or implementing alcohol screening at the practice level. And those of you that are participating in our behavioral health initiative, we would be more than glad to help you in implementing any of these tools to help you with brief advice, to develop referral bases, and move on from there. And my email address is coming right onto the chat box now. And I think if we don't have any other questions, if you guys will just please fill out the evaluation questions, we are done for the day. I hope you guys have a great afternoon and a wonderful, wonderful holiday season. Please be safe and healthy.
So, ladies and gentlemen, thank you for joining the conference. You may now disconnect, and I hope you have a wonderful holiday season. Thank you for your time.